All right, thanks everyone for coming, both virtually and in the room, for Grand Round today. For those that don't know me, my name's Emily Rowe, and I'm stepping in for Jo as chair today, so welcome. Firstly, I'd just like to acknowledge that we meet on the traditional lands of the Kaurna people and pay respect to their elders, past, present and emerging. So our talk today is a very stimulating one and is kindly going to be delivered by Dr. Kate Lynch from the Gastroenterology Department. She's head of inflammatory bowel disease here at the RA and is, I understand, a gastroenterologist and a hepatologist. So welcome, Kate, and we look forward to hearing about your talk, Primary Sclerosing Cholangitis, the black box of hepatology. And we have a very special guest online today, and that's Kate's mum, so welcome.
Thanks very much for that kind introduction, and thank you to the medical organising committee for asking me to speak today. These are my disclosures. So this is an outline of my talk today. I'll start off with a case study because I think it just sets the scene, and I don't know how many in the audience will have seen a patient with primary sclerosing cholangitis, or you may not have seen many. I'll talk about what PSC is and how we establish the diagnosis as well as the management. I'll go a little bit into assessing prognosis, and then I'll go into an area of my research, which is the utility of the biologic vedolizumab, which targets gut-homing T cells in PSC-IBD. And I'll also just touch on future therapies for PSC, including a clinical trial we have here at Royal Adelaide. So this is a patient I had in Oxford when I was there, which was from about 2012 to 2019. So this young man was doing his A-levels, which is a bit like year 11, 12 at UK. And he was referred because he had some GI symptoms and he also had some abnormal liver tests. So he had some diarrhea, fatigue and crampy abdominal pain. On further history, he had some urgency. He had a family history of ulcerative colitis. He had no blood in his bowel motions and he regularly exercised. He drank alcohol in a binge pattern, so once or twice a week, but not regularly. And he had no liver symptoms. Clinical examination was largely unremarkable, apart from a slightly tender lower abdomen. These are some of his baseline investigations. You can see he had an anemia. It was a microcytic anemia with iron deficiency, a ferritin of 12, and he had cholestatic LFTs with the GGT and the ALP more elevated than the hepatic enzymes. And he had negative stool culture for infection. So he underwent a flexible sigmoidoscopy, and this is a fairly classic endoscopic appearance of what we see for moderately severe ulcerative colitis, where there's complete loss of the vascular pattern, complete denudement of the mucosa really with erosions. And he had moderately severe on the endoscopic index of severity score, the UCEIS. And the biopsies were consistent with chronic inflammation, consistent with ulcerative colitis. So he was commenced on mesalazine, the brand of which was Pentasa at high dose orally. And within a couple of weeks, he had a rapid response of his colitis with formed bowel motions, no abdominal pain. He did come into hospital shortly after that for a flare and required some steroids and was commenced on immunomodulator and azathioprine. But otherwise, after that, he had a fairly quiescent course of his colitis. And he did have a colonoscopy shortly after diagnosis, which showed it was the whole of his bowel that was involved, but worse in the right colon with a normal terminal ileum. We'll come to why that's important later. But we haven't talked about his raised alkaline phosphatase, where normal is less than about 120 and his was 2000. So, and I must say that with 16-year-olds, you often have a higher reference range for ALP up to about 800 or 900 because they have a lot of bone ALP from growing bones, but it's obviously more elevated than 800, 900 even. So this is a chronic liver disease screen, and if you work in a hospital with electronic medical record Sunrise, you've got a chronic liver disease screen bundle, which has all of these tests, which is very helpful if you can't remember all of them. But you can see that the things that came out was a few little autoimmune factors. He had a positive ANA, but it was low titer, 1 in 80. He had a positive ANCA. It was a P ANCA, but a non-specific P ANCA. And he had just slightly raised IgG levels. And so he went on to have an MRI scan, because this is the way we diagnose PSC, which I'll talk about soon, a cholangiogram, which was normal. So he went on to have a liver biopsy, and hopefully you can see my cursor. This is the bile duct here, and around it you can almost see some onion ringing, so like onion ring skins around this bile duct. And that's what you see in PSC. You see fibrosis, this onion rings around the bile duct, which is fibrosis around the bile ducts. This is one of the hepatic vessels. And if you do a particular stain for fibrosis, you can see that this is all fibrotic tissue around the bile ducts. So he came up with a diagnosis of small duct PSC, and we'll tell you what that means, which has a reasonable prognosis, and he underwent various surveillance for various things, which we're going to talk about today. Over the course of time, his LFTs were still quite raised without any treatment, and he had a repeat MRCP, which actually showed some changes, which previously it was normal. And I'll talk about some of those changes you see later. So we thought he'd progressed from small duct to classical PSC. And so he was started on ursodeoxycholic acid and at a dose of 17.5 milligrams per kilogram. He was considered for a trial of a new novel therapy, but considerations with this young man is, what is his prognosis? Someone with ulcerative colitis in remission, but PSC, classical PSC, what do we tell this person? You know, a man right at the start of his life with a lot of lifespan ahead of him. So let me help you answer some of those questions. What is PSC? It's a progressive inflammatory condition of the liver, which we don't really diagnose until it gets to the stage that inflammation has led to fibrosis, when you start getting strictures of the bile ducts, which leads to the narrowings that you can see on the MRI. And as a result of the narrowings in the bile ducts, the bile doesn't flow so well. So you get cholestasis, you get backing up of the bile, and that's why you get these cholestatic LFTs with the raised ALP and GGT. As it progresses, that fibrosis goes from around the bile ducts and spreads through the liver, so you can get cirrhosis of the liver. But it is intrinsically linked with inflammatory bowel disease, and the proportion of people with PSC who have inflammatory bowel disease varies depending on geography. So most studies have been done in the Northern Hemisphere, and you'll see a rising prevalence of IBD the further north you go from the equator. So the prevalence of IBD and PSC in Spain, for example, is only about 50%, compared with Norway, where it's about 80–90%. And the Australian figures are at about 70% right now from a recent study. It's a rare disease, up to 16 per 100,000, and it carries a poor prognosis. So some of the early studies from about 20 years ago, 28% at 6 years. But there's no proven medical therapy to prevent someone's liver disease progressing, which is awful. And liver transplantation can be a cure, although it can recur. So it's predominantly males, about 2 to 1 males, and the median age is about 40 years old, but it can present anywhere from childhood through to 70s, 80s. But it is increasingly a young person's disease for diagnosis. There is an inherited predisposition. There's about the most strong gene involved with PSC is an HLA phenotype. And then there are some other immune genes, but it's a complex genetic disease in that genes predispose you, much like celiac disease, and then there's some environmental factor or factors that trigger it. I've mentioned the link with IBD, but the etiology is unknown. That was part of what my PhD was about, to try and look at the pathogenesis, and I'm afraid I didn't come up with the exact answer. I came up with some clues. There's some theories about a leaky gut theory, where patients have inflammatory bowel disease, they have increased permeability of the bowel, and certain antigens from bacteria or other antigens can get through, delivered via the portal system to the liver, and upon exposure there can create the mischief, the heightened immune response in the HLA susceptible person. There's also a question around gut homing T cells. So there are certain T cells which are primed to go to the gut, and they have been associated with PSC in the liver, and I'll be talking about that too. In terms of the phenotype of the inflammatory bowel disease, I mentioned the majority have it, but the majority have ulcerative colitis with a small proportion Crohn's disease, and that should say 5%, sorry, IBD unspecified, which is when you have some features of both ulcerative colitis and Crohn's. But the main thing to say is that it's actually almost always a pancolitis. It involves the whole of the large bowel, as opposed to a proctitis, just in the rectum, or just an ileitis, which you often see in Crohn's. So it's usually the whole bowel. It often can be worse severity on the right-hand side compared with the left. There's often rectal sparing, which is very rare in ulcerative colitis, and they get a little bit of ileal inflammation, what we call backwash ileitis. So there is a very clear phenotype of the IBD. And in my opinion, you know, I've told you 80% UC, 15% Crohn's, but I actually think PSC IBD is its own phenotype, and it just depends what people call it, depending on certain factors. And I do have some data, which I'm not presenting today, that shows a distinct immune phenotype at a cellular level of PSC IBD as opposed to ulcerative colitis. But one of the problems is that people with PSC and IBD are at 5 times the risk of developing bowel cancer than if you had UC alone. So, and it can happen between their annual colonoscopies. We don't know why that is, and I won't go into some of the hypotheses now. The clinical features in patients with PSC, so it's often just an asymptomatic patient with IBD, and you're doing their liver tests and they have cholestatic LFTs and you investigate and they've got PSC. But some of the symptoms they can get include right upper quadrant pain from stretching of the liver capsule, lethargy and pruritus. And also abdominal pain is a big feature as well, but whether that's their IBD or their PSC is unclear. Weight loss, jaundice, organomegaly are signs of more advanced disease. So how do we diagnose it? So we've got some guidelines to tell us how to diagnose it, including EASL, which is the European Association for Study of the Liver, AASLD, which is the American Association for Study of Liver Disease. ACG is the American College of Gastroenterology. So those two A ones are the hepatology and the gastro side of America. And BSG, the British Society for Gastroenterology. But the best ones, which are a tome, that I still haven't quite finished reading them, are the ones that came out in June this year, which are the ones that I've highlighted there, the EASL ones, which are excellent. You basically have to have chronic cholestasis, which you can just use LFTs for, your GGT, your ALP. They don't say how long it has to be for, 6 months or 3 months, but I guess if you've got a one-off isolated reading and then it normalizes, that's not going to be enough. And you have to have stricturing of the bile ducts seen on some sort of imaging. So usually we use MRI, MRCP, although in the olden days we were using ERCP, an endoscopic cholangiogram, or you can also do intraoperative cholangiograms. I do have one patient who was diagnosed that way when she was having her gallbladder taken out. If you don't have characteristic findings on cholangiogram, then and you're still highly suspicious, that's when you can do a liver biopsy, and I'll talk about that shortly. There are quite a lot of secondary causes of sclerosing cholangitis. That's where the term primary comes from. Primary sclerosing cholangitis means you have strictures of the bile ducts which are not identified due to some other factor. So we don't like an idiopathic cause. And there's a long list there, and I think I've kind of highlighted the ones that are probably the most important for our population we see in Australia. But IgG4 sclerosing cholangitis is its own talk, which I won't go into, but sometimes we do, that can be a separate entity from PSC. So the investigations that we perform if we're diagnosing someone with PSC, obviously the LFTs, the blood count INR to look for signs of decompensated liver disease or portal hypertension. And the P anchor is positive in a non-specific fashion. In my populations I've seen in the UK and Australia, it is more like 80% of patients. And probably about 30 to 40% of patients with ulcerative colitis have a positive anchor. So it's not specific, but it does heighten my thoughts about whether they have PSC. We do ultrasound, and I'll tell you why shortly. And we definitely obviously do an MRCP as a diagnostic test. And we only do the liver biopsy if the MRCP is not conclusive, or if we're suspecting an overlap with the condition autoimmune hepatitis, which occurs in about 10% of people. And these are people with very high transaminases, more than 3 times upper limit of normal, or very high IgG. So we do find that patients have a slightly elevated IgG, but I'm not worried if it's not above 20. And we also find their transaminases go up a little bit, but unless they go up above 3 times upper limit of normal, I'm not too worried either. So I think I've covered some of this. That these are the cases when we need a liver biopsy, but there could be a prognostic value. And there was a study that I was involved with colleagues in Amsterdam, where they used something called the NACA, or they used 3 different systems called Ishak, Nakanuma, and Ludwig, which are histological reporting indices, predominantly for primary biliary cholangitis, another biliary disease. But we found that the Nakanuma stage, which is to do with the fibrosis stage, actually correlated with your prognosis. So we wouldn't do a liver biopsy just to prognosticate, but if you do get a liver biopsy, then you can use it to help prognosticate what that patient's survival is. These are the British guidelines, which are in keeping with what I said, not to do liver biopsy and do non-invasive assessment. So I've talked to you about what we see on the H&E stain on the left, and on the right is a fairly old MRCP, but you could probably make out all of these intrahepatic ducts very dilated here, and below there's a narrowing, dilatation here, and there's a narrowing before. So the white is the fluid, the bile going through the bile ducts, which shows us the shape of the bile ducts. And you tend to see strictures, which is an absence of it's black, but then above it, proximal to it, is a dilatation, because you get dilatation proximal to a stricture. So in terms of small duct PSC, this is to do with if the bile ducts are normal on the MRI scan. In other words, you can only see large bile ducts on the MRI, you can't see the very small ducts. So if the MRI is normal, then your large ducts are not affected, or it's a poor quality MRCP. But hopefully you'll have had a good quality MRCP that's normal. If you're still suspecting they may have PSC, you do a liver biopsy. And obviously on a liver biopsy, you've got the microscopic small bile ducts. And then you can see changes of inflammation and stricturing around the bile ducts. And so I've kind of shown there where the large ducts are. I've probably put my square a little bit low because some of these early order intrahepatic ducts also are slightly larger duct. But the small duct PSC has a much better prognosis. So here's a Kaplan-Meier curve where you can see the liver transplant-free survival. So higher is better when you have you're alive and you don't have a liver transplant. And in blue are patients with small duct, compared with people who have classical PSC or overlap with autoimmune hepatitis. So there's a much better survival for small duct PSC, but about 25% of patients with small duct will progress eventually to classical PSC, and then they have the same prognosis as those with classical. So if they don't have inflammatory bowel disease when they're diagnosed with the PSC, we should do a baseline colonoscopy. And so we should do a full colonoscopy, not just a flexible sigmoidoscopy. And we should do biopsies because they could have quiescent IBD. And we should repeat that exam every 3 to 5 years because for some reason they have a fairly quiescent disease. They may have inflammation but not have many symptoms. So I tend to screen them every 5 years if they don't have IBD but they're not at increased risk of bowel cancer if they don't have IBD. So this is taken from the British guidelines where it's a fairly good algorithm and a fairly good thing to refer to as a non-hepatologist if you've got someone you're questioning PSC. Got someone with cholestatic LFTs, they've had a normal liver screen ultrasound, you do an MRCP, and then what you do from there. So how do we manage it after we've diagnosed it? Well, they are at increased risk of bowel cancer, I mentioned. So if you have IBD, you get an annual to 2 yearly colonoscopy. Whether or not you use dye spray, which is a blue dye, either indigo, carmine or methylene blue, depends on the endoscopist. There aren't clear studies showing that helps, but that's what I often use. And we are looking for subtle areas at the colonoscopy that look different, that look dysplastic. And it takes an expert endoscopist to do this who does a lot of surveillance colonoscopy. And you can find patients who are having these scopes who don't have a whopping cancer there, but just have this subtle mucosal difference, which is an area of dysplasia from previous inflammation. And we tell them to get their bowel removed because they almost all go to bowel cancer eventually if they're left there. Cholangiocarcinoma, we've all heard of. It's got a dismal prognosis, although I have seen some patients who survived the diagnosis. But I've said 5 to 10%, but the prevalence of cholangiocarcinoma and PSC varies widely depending on what study you look at. And it's a devastating diagnosis. There is no screening available. We used to use CA19-9, but actually that goes up just with inflammatory strictures and it's more confusion than it's worth. We sometimes use CA19-9 if we see a stricture that is concerning on the MRI. But I haven't included a slide in this talk, but we're tending to do MRCPs yearly to 2 yearly as a screening test for cholangiocarcinoma. That's unproven as a screening strategy. There is a small risk of gallbladder cancer, and many of you will have seen ultrasound reports which shows a 3-4 millimetre polyp of a gallbladder, which we normally just survey. In a PSC patient, unless they've got advanced cirrhosis or comorbidities, I ask the surgeons to take it out because there is a high risk of it becoming a gallbladder cancer. And they are at risk of hepatocellular carcinoma if they have cirrhosis. So we do a 6-monthly ultrasound. So in general, I'm seeing patients with PSC 6 monthly to yearly. or more often if there's issues. But what am I actually going to give them? Well, I'll go through URSO on the next slide, but they are at increased risk of osteoporosis, so you need to screen for that. And it's actually very surprising, these young men with osteopenia, and I'm very aggressive. I almost just put all of them on vitamin D, even if their vitamin D levels are fine. I've said about the ultrasound, etc. And liver transplantation, I'm not talking about today, but it can be an excellent treatment. But obviously you don't want to do that for all of them. It has to be once they meet criteria, when they have decompensated cirrhosis or if they have intractable itch. But there is a 30% recurrence rate. And there was a case study I heard about at a liver masterclass in Noosa recently of a patient in the eastern states who was on their third liver for PSC. And they were asking all of us, have you got any other ideas? So there are some people who do recur. So these are the studies, the 14 studies of ursodeoxycholic acid, which most of you will be familiar with as a treatment for primary biliary cholangitis, PBC. We've got lots of bile acids, bile salts in our bile that our human body makes, and about 4% of the bile acids we make is ursodeoxycholic acid. But if you give someone a synthetic form of urso, you enrich it to a degree that about 50% of your bile salts are urso. So theoretically, it could be that you're enriching your bile salts for a good bile acid, because there are good bile acids and bad bile acids, we think, in terms of irritability to the bile ducts. So I want to highlight a few of these studies. The top box in blue, Burrs et al. In 1992, was one of the first studies that was placebo-controlled looking at URSO and PSC, which showed that the liver biochemistry improved. And then there was this larger study by Kate Lynch in America in the late 90s, which again showed that the liver biochemistry improved against placebo. And I might just interject here to say that there are very good studies, about 5 at least, to show that if your ALP comes down to a certain level, that's associated with a good prognosis. And if you have persisting raised ALP, that's a bad prognosis. So it's probably our best surrogate marker that we have. So that's why I'm kind of pointing out whether the liver biochemistry improved here. So in the second to bottom one in the aqua box is Olsen et al., which aimed to recruit about 300 patients. It was powered to detect a difference between URSO and placebo in terms of preventing death or liver transplant if they recruited 300 patients. But unfortunately, they only recruited 261, and they didn't, I think it was about 320 or 340 they had to get to. So they actually did find a difference in the number of patients dying or needing a liver transplant, but it wasn't statistically significant. And they just didn't reach their power calculation. So the Olsen study is probably the best study, the largest study we have. The liver biochemistry improved. There was a numerical trend. But these studies are just so hard to recruit for because of the rarity of the disease, the heterogeneity and people meeting inclusion exclusion. So a lot of people look at that Olsen study and say, actually, URSO may have an effect, we just haven't been able to prove it. So Lindor et al. Then went on to do another study using higher dose. You can see in the third column the URSO dose. These doses are getting higher than what we use in PBC. So the one I just mentioned was 17 to 23 milligrams per kilogram, whereas the dose in PBC is 13 to 15 milligrams per kilogram. So in Lindor's, they did double the dose used in PBC, but unfortunately, there was a mortality excess in the URSO group compared to placebo, and everyone stopped prescribing placebo. So that was a bit worrying, although the liver chemistry did improve. So my summary of these trials is that there have been multiple well-designed studies, and they've almost all shown an improvement in the liver biochemistry. And there was this one large study that suggested a disease progression benefit. We know that higher doses, double doses, are harmful. I haven't shown it here, but there are studies showing a chemoprotective effect in terms of reduced bowel cancer. And there's another study, which I haven't shown, where if you stop someone's URSO with PSC, their liver tests bounce straight back up very quickly, which has to be a bad thing, one would think. So my take on it is that I think there is a subset of patients who respond to URSO. We just don't know what subset. It's a fairly benign drug if you're not using it at extremely high doses, and that we use so many other drugs which have low efficacy profiles with significant side effects. Like I remember when I was a registrar and people with hepatitis C, I was giving pegylated interferon, and they had awful side effects. They were becoming psychotic, and they had cold and flu symptoms with only a 40% chance of responding. And then we use azathioprine and biologic therapies in IBD, which have significant side effects in a small proportion of people. So my take is that we use urso, we give a trial of urso and only continue in those who have a biochemical response. It's not licensed for it, it's off-label. So the specific symptoms of PSC, I've put cholestyramine there, but that's because I didn't update my talk as of a couple of months ago, where the new EASL guidelines just go straight to rifampicin, an antibiotic, because cholestyramine tastes awful. It's like this chalky resin that's actually licensed for raised cholesterol. It's an old-fashioned cholesterol drug, and it's a resin that binds up cholesterol and various lipids, etc. But it binds bile salts, and so if we think the bile salts are the thing that is causing the pruritus, which is up for debate, then it can help with your itch. So I find it helps about 20–25% of people, but patients hate it. It tastes like chalk, and I do have some people who love it because it helps their itch. But rifampicin works pretty well, but you stain their secretions, their sweat and their urine, etc. goes a bit orange, and you have to watch their LFTs. Now trexone, and I didn't put their SSRIs, are also, there's a few case studies for these. Patients can get recurrent cholangitis from their strictures, and so often we treat this very urgently with antibiotics, and they may have a script at home for either having cycling antibiotics or intermittent antibiotics. And the lethargy is hard to treat, and actually if you give someone a transplant for their PSC, it doesn't actually necessarily improve their lethargy. So we are very hot on screening for other causes as well, and they often are vitamin D deficient. So I'm going to try and whip through prognosis, but just kind of mention some of them. Some of the ways we work out prognosis. A significant proportion of people decompensate, die, need a liver transplant, or get cancer. And actually the leading cause of cancer in patients with PSC is actually, the leading cause of death in people with PSC is actually malignancy. And then the next one is liver failure. So malignancy is, and that's because of the high mortality rate of cholangiocarcinoma, whereas with liver failure, we can give a liver transplant. So the median survival was said to be 10 years in this liver transplant cohorts in the grey, but when they looked at centres that also are non-transplant centres, they found the median survival was about 21 years. It's still not very good if you're being diagnosed at 20 years old to be told, you know, that there's half a chance you'll either die or need a liver transplant by the time you're 40, which I tend not to say it like that to my patients, but, you know, you have to be honest with them if they ask. And we know that the raised ALP confers a poor prognosis. So the largest study that we have looking at prognosis in PSC was an international collaborative effort of the International PSC Study Group, of which I'm a member. And there were 53 or 50 Adelaide patients in this cohort of 7,000 patients. We were the only state in Australia to contribute patients. And that was thanks to Deb Quinn and John Bate. It was, I contributed Oxford patients. So 7,000 patients, which is huge for a PSC study. Most PSC studies, you're lucky if you get 250 in a cohort. And we had a pro forma that was filled in by all the participating centres, and the mean follow-up was 9 years. And so we looked at different variables that conferred poor prognosis. So the first ones to mention are that if you're diagnosed at an older age, that's the top graph, that your prognosis is worse. Whether or not that's just because you're older and you're going to die sooner is unclear to me. And also women had a slightly better prognosis than men, but I don't think that, even though it was statistically significant, I don't really feel that that was numerically or clinically as relevant. The small duct PSC came out very strongly. So these are two cohorts you can see with 240 and 590 patients where small duct came out with a better prognosis. But you can see here, I think this is the graph I showed earlier, this is with the 7,000 patients. So all studies have shown small duct have a much better prognosis. Crohn's disease is coming out as a better prognostic factor as well. Now, this is not due with bowel cancer, this is overall liver transplant-free survival. And I tend to think this might mean that you have slightly less inflammation, because I've told you I think it's all the same IBD, so you might have more patchy inflammation. But in any case, if you have a phenotype that resembles more that of Crohn's and of ulcerative colitis, you have a slightly better survival. This is a study that came from Oxford that came out just when I arrived there. And if your serum alkaline phosphatase, which is what the SAP is, persistently improves to less than 1.5 times the upper limit of normal, no matter whether you've got URSO or not, you had a better prognosis than those with a significantly raised ALP. So the ALP is probably the best prognostic marker. And this is just a summary of the 5 studies that have looked at ALP as a prognostic marker. And you can see that they had different endpoints, 40% drop, normalisation, reduction to 1.5 times the upper limit of normal. But they all used liver transplant, death, etc. And they all showed that ALP was useful. IgG4 level, I'm going to skip over. FibroScan or transient elastography, FibroScan's the brand name, correlates with the amount of fibrosis you have on a liver biopsy. So the higher the number or the stiffness on the liver on the FibroScan, the higher amount of fibrosis you have on your liver biopsy. But there are studies looking at cutoff points on your FibroScan. So the best validation of FibroScan in liver disease is in hepatitis C. We often use numbers of 13 or 14. So above that, people have cirrhosis, and below about 6 or so, very little chance of them having significant cirrhosis. So when they cut them into groups of less than 9 or greater than 9, that greatly conferred a prognosis outcome, and even more so if you use 18.5. And people with PSC get huge FibroScans. I get people in the 70s, which I don't really see in many other diseases. So, and that can reflect some portal hypertension because they get a lot of portal hypertension. But I'm very reassured that they've got a nice low FibroScan, and I tend to do that yearly to 2 yearly. And there's a prospective study looking at FibroScan and PSC, which should hopefully report on soon, that's being done in Europe. There are some scoring systems. This is one I was involved with, the Amsterdam-Oxford PSC risk score. You can see the subtypes, small duct or large duct, the age, your albumin, your platelets, your AST, your ALP, your bilirubin, which I don't use in clinical practice, but I do for medico-legal things. And this is you just type it in an Amsterdam-Oxford PSC score, and it's very user-friendly, and you get this graph. And so medico-legally, you can tell the court or the insurance people what their prognosis is. And this is another risk score that I was involved in with slightly different parameters. But overall, we're not using them in clinical practice. The ELF score, I don't know if anyone's heard of ELF, but this is a serum blood test where they measure certain circulating markers of hepatic matrix metabolism. So they're actually measuring fibrosis from the serum. And unlike a FibroScan, which is just one small patch of the liver, same with a liver biopsy where you may have sampling error, this is a little bit more generalized as to the fibrosis within the liver. And they divided people with PSC into lower, middle, and upper tertiles, or the numbers, the thirds. And it was clearly associated with prognosis. And I've only just shown one study here. So this test is not available on Medicare. You can get it with ClinPath, and it's about $190. And I am offering it to my patients now because I think it's probably better than FibroScan. And it depends on the patient whether they're willing to pay. A dominant stricture, I should have changed the slide, sorry, because they're now called high-grade strictures. But a dominant stricture or a high-grade stricture is really just a really obvious, very narrow stricture. They are much more likely to be cholangiocarcinoma than just a mild stricture. And a large report, but they can be benign. But if you have a dominant stricture, then you have a worse prognosis, and probably partially because of having cholangiocarcinoma in some of them. But I forgot to show the graph here. They then looked, this is a UK study, they were able to actually also separate people who had a benign dominant stricture versus no dominant stricture, and it was still a worse prognosis. I think it makes sense. If you've got a very tight stricture, you may have recurrent episodes of cholangitis, you're having less bile flow, and so the exposure of the bile ducts to antigen and therefore progression of the disease will be higher. So this is the next part of the algorithm that I was mentioning from the British guidelines, which once you've made the diagnosis, how do you risk stratify it? How do you stage disease? How do you manage it? And how do you survey them? So again, I think this is a really good tool for anyone looking after PSC, for physician trainees, etc. Anyone who is interested in coming and doing some research with me in PSC and wants to help manage any of the patients. So now I just want to touch on a slight research area. And so my PhD was on gut homing T cells in PSC IBD. And we target that mechanism in inflammatory bowel disease, Crohn's disease and ulcerative colitis with a drug. So can we repurpose drugs that we're already using in IBD for PSC? So some of these things are what I was looking at. And I'm not going to show you my basic science lab things today because I thought that might be a bit much for the audience, but I'm going to tell you quickly about the integrin that we're talking about. So alpha-4 beta-7 is an integrin which was first described back in the 80s, and it was called ACT1. And it's present on a lot of different immune cells, not just T cells, it's on a lot of innate white blood cells as well. But it's on about 50% of CD4 T cells, T helper cells. And its highest expression is on memory T cells. And the main ligand for it is called NADCAM1, mucosal addressing cellular adhesion molecule 1. But it also interacts with 2 other ligands. And alpha-4 beta-7 is highly expressed on T cells which have entered the small and large bowel. And there's limited expression besides in the peripheral blood and the intestine. So this is a little schema showing you the T cell whizzing through the blood vessel in the intestine. And the orange is the chemokine receptor, which is CCR9, responding to its ligand, CCL25, which just causes it to slow down. And if these bind, that causes the alpha-4 beta-7 to be expressed, or sorry, activated, which then can bind to its ligand on the endothelium in the gut, MADCAM1. So I didn't mention the first step, but basically there's a flow of steps that occur that cause activation of alpha-4 beta-7 to then bind to its ligand. And then it stops, it's arrested in the blood vessel instead of flowing through. And it then squeezes through tight junctions between the endothelial cells and gets through into the lamina propria. So that's how a T cell is recruited to the lamina propria of the gut. There's no other way. Unlike the liver and other places where they can get through spaces of discs and various other, and there's some other chemo-attractive ways of them being recruited. This is the way T cells get to the gut. And we know that there's overexpression of CCR9 and alpha beta-7 in the gut in IBD, and we know there's overexpression of their ligands in the endothelium in IBD. And so if you target those and block them, you'll have less T cells coming in and have less inflammation in the gut. Oh, here we are, there's mine. So I think I've got so this is it binding here, but vedolizumab, the pink antibody there, binds to alpha-4 beta-7, and so it stops that binding so the cell can go on its way. But there's been no human studies to date showing that it reduces T cell trafficking. And I'm not sure why I put that in today's one, because I'm actually not going to show you the data that I've got from that. But anyway, I have some data on that, but they weren't before I did it. This is the Gemini study. This is the landmark study of vedolizumab in IBD, in ulcerative colitis. And against placebo, you can see 25% of people on placebo got a clinical response, compared with 47% on vedolizumab, and a much higher change of remission, which is a harder endpoint. And mucosal healing is when it's not reliant just on symptoms. You actually look and see that the inflammation has resolved. So we know that it works. We have wonderful results in a subset of patients with UC with this drug, vedolizumab, or Entyvio is the brand name. And the benefit in Crohn's is there. It's not quite as good a benefit as UC, but we do see it helping Crohn's. So what about in the liver? Well, MADCAM1, which is the ligand for alpha-4 beta-7, has been shown to be present in the liver in PSC. It shouldn't be. So in the healthy liver, there is no MADCAM1, so there's no ligand for the alpha-4 beta-7 T cell. However, 20 years ago, there were diseased PSC livers that a Birmingham group showed that MADCAM1 was present by immunohistochemistry in the diseased livers, but particularly in PSC. Furthermore, they extracted liver T cells and looked at the proportion which was CCR9 positive, which is a gut-homing T cell, and found that in PSC livers, about 18–20% were positive for this gut-homing marker, compared with normal livers, which were 0. And this is the Crohn's disease lamina propria, where they almost all were positive for CCR9. So the rationale is that there are some data showing that there are these integrins, chemokine receptors and ligands in the PSC liver. And we know that the lymphocytes are a predominant pathology on the liver histology. And we also know that there's a strong HLA association in PSC, which indicates an antigen-driven T cell pathology. And we know that the IBD and PSC are intrinsically linked. So can vedolizumab block T cells entering the liver in PSC? Can it reduce inflammation? So I diverged for a moment to tell you about one of my patients in Oxford. And this is his ALP. He had colitis as well as PSC, and the normal range for the ALP is between these two red lines. So you can see he had raised ALP. I started vedolizumab. He had a huge rise in his ALP. He stopped the vedolizumab. It got better, and that was that. So that's a little bit concerning. His ALP rose after starting vedolizumab. Then I had another patient who vedolizumab was started and the ALP dropped precipitously. Then he stopped it because he stopped turning up for his infusions. We eventually re-engaged him and he restarted it, and it's down to low levels for the first time ever. So we've got these paradoxical patients. So the published experience so far, a 7-case report series, and the largest group were, 75 patients until our international group. And this is an Australian Chicago series. I wasn't involved with this, which showed that a subset of patients whose ALP was raised to start with had the ALP reduced from week 0 to 14 on vedolizumab. And the JETAID study from France, they looked at 54 patients with PSC starting on vedolizumab, and there was no difference in the ALP. I'm going to just skip over that. So this is the International PSC Study Group experience, which I led, which was 20 centres, and the centre I was involved with was Oxford, but I collated all the data. And if you were a patient with PSC who'd received vedolizumab for your IBD, then you were excluded. And we looked at the response of the IBD and the liver test, as well as liver-related events. I'm going to skip over this. So we actually showed that over time from baseline to last follow-up, there was a rise in the mean ALP. And so from 242 to 306, and they had an equivalent rise in ALT, AST, and bilirubin. Somewhat concerning. If you look at it a different way and don't put everyone together and look at the mean change, you can look at, well, what proportion had an ALP drop or an ALP rise? And actually 20% of patients had an ALP drop by at least 20%, which you don't normally see. And most of them stayed the same, and 20% had a rise. If you look at what kind of variables predicted you having an ALP drop in the vedolizumab, there was a little bit of a difference whether you had UC or Crohn's, or if your ALP started off high, but they weren't to statistical significance. But if you had cirrhosis at baseline, you were more likely to have an ALP drop by at least 20%, which may indicate a person who's got a more progressive inflammatory disease that may be more susceptible to vedolizumab. And that came out on the multivariate analysis. Their IBD responded. I'm not going to show these data, and they tolerated it. So I'm just going to skip through for the sake of time. But I guess to summarise that data, vedolizumab overall caused a rise, but there were subsets of patients who had a drop, and that the IBD responded and appeared safe. And so in other words, I think that it's so heterogeneous, there may be a subset who vedolizumab can work for. And so if we start someone on it, we look at what's happening, and if it's working, it works, but if it's going up, we have to stop it. So last of all, I'm just going to talk on future therapies. Norursodeoxycholic acid is basically urso, but with one less side chain. But taking away that side chain, that carbohydrate side chain, has a massive difference on the effects. So it has anti-fibrotic, anti-proliferative, and anti-inflammatory effects, and it's very well tolerated. So this is a mouse model of PSC. So on the left, the wild type mouse is a normal mouse. This is H&E stain. This is a wild type. This is the fibrosis stain of a mouse's liver with PSC. When you knock out something called MDR2, you get PSC. You can see all of that fibrosis around the bile ducts. If you give them urso, you still have some scarring, but it goes down. If you give them norurso, it melted away. So this is very exciting. And so then this is a study I was involved with, unfortunately not to the extent that I was an author. In Oxford, I had about 5 patients on this drug, and we gave them 3 different doses of norurso, so they were randomized to a placebo. And there was a clear drop in ALP depending on what dose you were given. So this is in phase 3 studies now, and it's an easy, benign type drug. And the proportion reaching that golden endpoint of less than 1.5 times the upper limit of normal was pretty good, 41%. There's another integrin called alpha V beta 6, which is on cholangiocytes as well as fibroblasts. I'm just going to skip through some of this, but again, we've got a mouse model of the PSC mouse, and when they gave them the drug, the scarring disappeared, and we saw their ALP go down in these mice. So we currently have a study recruiting at Royal Adelaide for this drug. It's an oral drug. It's being used in interstitial lung disease, and it's also being used in PSC because there are drug targets in the lung and the liver, and it's an anti-fibrotic. FXR agonist, farnesoid X receptor, is to do with bile acid metabolism as well as fibrosis, and there's one that's just been licensed for PBC, obeticholic acid, and there's also another one in development by Gilead called carlofexor. And the phase 2 studies of both of these drugs showed a reduction in ALP with both of these drugs, and both of them are in trials at the moment. Obeticholic acid study is only in US, and the carlofexor, we were about to be a site here, but then it closed. I tried to get on it just when I arrived in 2019, so that's ongoing. It should be reported on soon. So this brings me to my last slide to say that PSC is a complex disease. Thank you for indulging me on talking about my favourite topic. There are guidelines to help us diagnose it, how to survey people, and how to manage the PSC. And I've told you what guidelines the UK PSC and the EASL ones are the most recent. There's this inextricable link, which is great because I'm an IBDologist/hepatologist. So it means that I can keep doing my research in both areas, but it carries this awful prognosis. It's a devastating disease, and these people don't smoke, they don't drink, and they get cancer and they get liver failure with no fault of their own. We've got numerous prognostic markers that we can use, but if you have a patient with PSC, I think they should be treated in a tertiary centre by someone who knows about PSC, even though I'm not really making any of them better, although I think that I am giving them some drugs that may help, but we just haven't got it proven in a statistical fashion. So thank you very much for listening. I'm happy to take any questions.
Thanks so much, Kate. That was a really brilliant and informative talk. We don't have any questions online yet, but for our online audience, please feel free to put them in the chat. Do we have any questions in the room? Yes.
Simple question. The ALP, you gave a figure of greater than 1.5 ULN.
So I'll repeat the question. So someone asked, what's ULN when I'm saying ALP 1.5 times ULN? Sorry about that. So the upper limit of normal. So when we get the reference range on the blood test, and it will say 40 to 120, the upper limit of normal is 120. So 1.5 times the upper limit of normal is about 200. So, and then depending on what lab and what assay is used, they have different upper limits of normal, which was an absolute pain when I did the international study from US and North America and had to look at everyone's upper limit of normal and then correlate them all. But yes, so look, and in the pediatric population, the upper limit of normal is a lot higher, and the old-fashioned assays, they're a lot higher. So it's more because there are different assays. But with our current labs that we tend to use here in South Australia, it's generally if it's above 200, the overall ALP.
Salam?
Okay, thanks for a marvelous course and excellent. I think they're complex patients because they've already got inflammatory bowel disease, which needs close follow-up, and then they've got this on top of it, isn't it? And the psychological aspect is pretty tough in a lot of these young patients, isn't it? Bringing them back for follow-up and procedures.
There was a comment from Delan Bartholomew's, who's seen a lot of these patients over the years, that they've already got inflammatory bowel disease, and then they have PSC and they're in and out of hospital with all of this uncertain prognosis, and it's a tremendous mental toll on the patient.
And it's great that you're involved in the research because that brings potential new therapies.
So I must say that they're hugely resilient, these patients, I find. And I don't know whether it's a lot of males and they're stoical and I don't realise how much of a mental toll they're taking, but we do have an IBD psychologist who meets all of our patients. And so her focus is on the patient's mental adaptation and psyche in relation to their illness. So at least we do have funded some resources for that, but you're right.
Okay, I'm going to ask you a question. So you mentioned that small duct PSC has a better prognosis than standard PSC. Mm-hmm. So apart from just perhaps a reduced burden of inflammation, what do you think is driving that difference in prognosis?
So the question was about small duct versus large duct. Why is small duct a better prognosis? Personally, I think it's two reasons. One is there is a much less inflammatory burden of the disease and probably less fibrosis. And the second reason is probably because their blockages are at a much earlier level. So you're still having bile flow, and so you're getting less infections, less antigen exposure. And that's the whole thing around dominant strictures or high-grade strictures being associated with worse prognosis. So all high-grade strictures are in the large duct. So it's probably that the lack of bile flow is less problematic for the patient with less antigen exposure.
Stephen?
In small duct disease, is there any overlap?
So the question was whether small duct PSC, is there an overlap in how it looks compared with PBC? So it's a completely different type of inflammation on the biopsy. The inflammation you see in PBC is a granulomatous inflammation, and it's got its separate genetic profile compared with PSC, which is a more T cell lymphocytic, I mean, still T cells in PBC, but it is a different type of pathology and different genetic drivers. So I've never had a pathologist get confused about which one it is. And also there's a separate antibody profile as well, which is helpful in the blood.
Kate, just to follow up, hopefully the audience online can hear my question, so you probably don't need to repeat it, but that's very delightful. Thank you. Early on in your talk, you mentioned that there was differences in the associational rates of PSC in people with inflammatory bowel disease based on their country of residence and their closeness to the equator. And I think you said that Norwegians had a much higher rate than perhaps we have in Australia. Obviously, the Norwegian diet and the Australian diet might have vast differences, but what other hypotheses do you have for that difference in population or country? Is it genetic or?
So most of the data is from Northern Hemisphere. And originally when I was starting my PhD, I wanted to look at vitamin D and PSC because I thought there is an association with PBC as well. It's higher, the higher north you go. And vitamin D has clearly got some T cell mechanisms that it affects T cells function, and lower vitamin D is obviously associated with autoimmune disease as well. So initially my thoughts were to do with the effect of vitamin D on T cell function. However, when we've done our recent study of 413 patients in Australia, our prevalence of IBD was similar to that in the UK, and we've got quite a lot of vitamin D. Although actually, if you look at most of our IBD patients, a lot of them have low IBD because everyone's slip-slop slapping, etc. So my hypothesis is it's to do with vitamin D and maybe something to do with diet. There are some dietary studies of PSC and of IBD which show clear dietary differences. And we know Mediterranean diet is actually a very good diet for various autoimmune diseases and chronic health diseases. So whether or not the Mediterranean diet is staving them from getting their IBD, I don't know, because down in Spain and Mediterranean area. But it's an interesting question that we don't have the answer to, the only hypotheses.
Brilliant. Well, let's please join me in thanking Kate for that brilliant talk.